Basically, the way that we have been learning neurology is the wrong way. A lot of times you learn about a disease, you look at all the characteristics of the disease, the presentation, and then you try to memorize in order to try to get your answer right. The way we should learn neurology should always be first having a fundamental approach, knowing the neural anatomy, knowing the function of the tissue that's damaged. That way, it could all make sense. You don't have to memorize anymore. If you know that if something in the brainstem is damaged, you'll already know what type of symptoms or clinical presentations your patients will have. Okay? So there's 3 ways we divide this very easily. I'm going to go from the cerebellum. You see the brain, the normal, the temporal lobe, frontal lobe, occipital lobe. That's the cerebellum. That's one thing. That has to do a lot with behavior, agraphia, writing, talking. A lot of that has to do with the cerebellum. Now, brainstem, that's the most important, in my opinion, the most important, because from this, you'll get a lot of clinical symptoms, a lot of signs that you can find just off brainstem damage. So that's what we really need to focus on. And of course, the spinal cord. We have to know exactly what tracts are going through where and what tracts are affected in what type of disease. Okay, so the way that we're going to approach this, let me just give you an introduction. First, we learn about the structure. Right? We learn about the structure. Then we learn about the function or what happens when it's damaged, the way it will present on a patient. That's like level 2. It's like a pyramid. Level 3, then we do the last part, which is incorporate all these clinical signs into diseases. So watch, it's going to flow very easily. The only thing is that the basics of this, you need to have a fundamental approach. You need to know it completely, right? Because from the base, from this class, the first stage is where we grow, right? Everything that we are going to learn today, we will attach it to further functionality, damage, approach. It'll all make sense in the end, okay? So we're going to simplify neurology. This should be the easiest subject if you approach it this way, all right? So first off, let's start off with the brainstem. Brainstem will consist of midbrain, pons, and medulla. Midbrain, pons, medulla. Basically, it's located right here. You're seeing this. So if I were to cover it up, you see the cerebellum this way, right? The brainstem should be here, the midbrain, the pons, and the medulla. Now, I'm seeing questions that actually have actual gross image of these structures. You would have to learn exactly how these structures look. This is the midbrain. This is the midbrain. Midbrain is divided by 3. Basically, you see this right here, this aqueduct. This is where cerebral spinal fluid can flow through. But we just divided by 3 right here, like this. This is called the tectum. Tectum, we say this is the tegmentum, and the crux cerebri. So this is the midbrain. We're going to dive a lot more into the midbrain. But for now, let's look at it like this. I'm going to draw it off like this. 1, 2, and 3. Now, if ever we're trying to diagnose any type of stroke, we want to know what vessels are involved. We don't want to memorize these lists anymore. Okay, we're going to have a fundamental learning when it comes to the brainstem. So there's 3 things we need to take into consideration. Whenever you're looking at a clinical vignette, don't just go off on autopilot. Don't just start reading it and then trying to gauge exactly what the answer can be. Have an idea in your mind. You see the stroke question and they're asking you what artery, what vessel is involved. Think to yourself first, cranial nerve. What cranial nerve palsy, what damage can I find in the question? Cranial nerve is super important. If you can uncover what cranial nerve is involved, it'll really give you a big clue to what area of the brainstem is damaged. Then, of course, you have tracts. Tracts will confirm your suspicion. And then you have, I call this brain function. Now, when I say brain function, I mean like complex functioning, like agraphia, acalculia. You can't calculate, you can't do math. You can, let's say, brain function. Those are the 3 things. 3 things that you should be looking for when you're reading a clinical vignette that has to do with strokes. And first priority to me is always going to be cranial nerve. Why do I say cranial nerve? Almost all the time, whenever cranial nerve damage is found, it's going to be ipsilateral. So if you're seeing that they're saying down and out, for example, that's when you have damage of cranial nerve 3. Down and out on the right eye. We're thinking, well, okay, well, it's the right side that's involved. It's ipsilateral. So that's really helpful when you're trying to find out what side or where the actual stroke is coming from. Ipsilateral. but be careful. This does get a little more complex because remember, some cranial nerves have afferent signals. For example, the corneal reflex is a cranial nerve 5. It can pick up afferent signals, but it sends it to both sides. It sends an efferent signal to cranial nerve 7 to close the eyes on both sides. So that's what I'm saying. So be careful. But what I mean is when you have a palsy of a cranial nerve, it's typically going to be ipsilateral. So that really helps. So let's look at it like this: midbrain, pons, and medulla. Let's put these cranial nerves into place. Cranial nerve 3, 4, 6, 12. So look how we're dividing this. On the pons area, we're going to further separate this by putting it like this: middle area. So anything that I'm drawing towards the middle, we're dividing it like middle. Anything on the side, we'll just say it's lateral. So the pons has a superior lateral side and an inferior lateral side. Superior lateral, we're going to put cranial nerve 5. Inferior lateral, we're going to have 7 and 8. Now, 8 has a couple of nuclei. It has like 4 different ones. You have a superior, inferior, lateral, and medial. And we'll get more into that. But first, like I'm saying, this is just the basics, right? We have to grow from the basics. There's a lot to talk about. But first, let's make sure we dominate this subject. Then from there, we start to add on more information. So right now, we're just drawing the brainstem and putting the cranial nerves where they belong. So since cranial nerve 8 has a couple of nuclei, you're going to see cranial nerve 8 expression as well here on the medulla. Now I'm also going to put 9 and 10. Okay. Now cranial nerve 11, you're going to see that it is involved in the innervation of several types of muscles. You're going to see it's called the accessory nerve. Can anybody tell me? Let's see if you guys know. I'm going to keep it a little bit interactive. Can anybody tell me what muscle does cranial nerve 11 actually innervate? If you know it, type it in. Trapezius and sternocleidomastoid. Good job. Yes, that is true. So let's be clear. Let's clear this up. Let's put it right here. Cranial nerve 11, at the level of C1 and C2, it innervates the sternocleidomastoid. At the level of C3 and C4, it innervates the trapezius. Remember, when you're going to do shoulder shrugs, you do this. That's the trapezius. Okay? So yeah, the accessory nerve, and it's located around the area of the anterior horn. You're going to see this cranial nerve here takes place, but it's not here. It's not too involved here with the brainstem, so we're not going to include this into the brainstem, okay? So far, so good. We have 3, 4, 6, 12, and then we have the lateral cranial nerves that we just put here in the list. This makes sense, but guys, it's not that easy because now we also have to add irrigation. Okay, so here's where it gets a little bit interesting. So when we look at the midbrain, you'll see that the PCA is actually giving irrigation towards the midbrain. Now, these are the internal vessels of the PCA. PCA has vessels that can go all the way towards the deeper inner part of the brain. Just to give you guys a reference of where we're talking about when it comes to the actual brain, remember that above the midbrain, you have the thalamus. So the thalamus is located above the midbrain. So just to give you guys some reference, this is the thalamus. This is the midbrain. They call this the superior colliculi, the inferior colliculi. And of course, you have your pons area. This is called the pons area. And then, of course, medulla. So yeah, I'm going to show you guys from all angles, from all approach. That way you guys can never get confused, okay? So PCA is the irrigation that we're looking at here when it comes to the midbrain. Now, let's look at the pons. Looking at the pontine area, I'm going to show you. On the middle area here, it's going to be the basilar artery. Then, of course, you have the pontine vessels that come off of the basilar artery, the pontine. And then, okay, so the superior lateral area, here we're looking at the superior cerebellar artery. Below that, you have your Pica, basically the anterior inferior cerebellar artery. And then, of course, towards the bottom here in the medulla, towards the middle area, you have your anterior spinal artery. And on the lateral, you have your Pica. Now, one thing I love about neurology is that everything needs to make sense. Everything will fall into place. So if you're looking at this and you're saying, hey, all these arteries are kind of hard to memorize and put them all together, I'm going to show you something right now. Take a look at the circle of Willis. If we put the circle of Willis right next to this, notice the sequence. Notice how the sequence follows the circle of Willis. The posterior cerebral artery right here, right? Let me put the screen a little better. Posterior cerebral artery. Let me put it side by side. Hopefully you guys can see. Check this out. Posterior cerebral artery right here. Basilar. right here in the middle. It's the same thing. Look at the orientation. Superior cerebellar, Ica, and Pica. Superior cerebellar, Ica, Pica. Okay, so it's following the circle of Willis. So that really helps us a lot. Okay, so we're not just memorizing random vessels here. We've seen the circle of Willis before. We could actually gauge this image to what we're learning right now. So, okay. So far, so good. If everybody's following me, everybody understands, let me know in the chat. If everything is good so far, let me know. So far, we're just talking about the brainstem. I gave you the cranial nerve positions. Now I gave you the irrigation. Okay. So far, so good. Everybody's good. We're going to move on. Okay. Next, I'm going to show you guys now a very important thing, because now we have the actual cranial nerve placed. Now we also have to have some basic understanding about tracks. Hopefully you guys can look at, let me show you the spinal cord. We'll adjust this spinal cord up real quick. Look at the spinal cord right here. If I were to draw this in here and ask you guys, this area here on the spinal cord pertains to what area? What area is this? Does anybody know? Feel free to type it in the chat. This area here? Posterior. Okay, so the posterior horn, let me tell you guys. Okay, so let's be clear. The posterior horn, when we talk about horns, we're talking about the gray matter here. When it comes to horns, we're going to be talking about this area right here. This here is gray matter. So when we talk about posterior horn, for example, we're going to isolate this area. That's the posterior horn. What we're talking about here is going to be called, yes, okay, so this is called the dorsal column. And the dorsal column is composed of two different areas. You have the fasciculus cuneatus and the gracilis, right? Posterior part contains the dorsal column. Yes, this here is the dorsal column. Dorsal column is going to give you basically proprioception, right? Let's understand that. It also gives you pressure, vibration, and fine touch. That's all dorsal column. Let's be clear. Let's keep it super clear. Here in the middle, you'll have the gracilis. So the gracilis, think lower extremities. And the trunks and above, think cuneatus, right? Remember, we used the reference of T1. T1 is the reference point. So that's the dorsal column. Okay, let's continue. So this is the way I could remember this easily. Here, right next to the dorsal column, you'll have another track right here. This track right here is going to be the cortical spinal tract. Cortical spinal tract. And I'll show you a way to memorize this. This is a motor track, right? This is a pyramidal track. And this is going to be something that allows you to engage in voluntary movement. This comes from the upper motor neurons in your brain. We'll talk more about this track and what it can do. But the way I memorize the placement of all these areas, it's very easy. Look, I split it in two. And I know one thing. Sensory is always going to be back here, right? Because the dorsal column is a sensory track. It's ascending. And right next to it, you're always going to have your descending, which is going to be, of course, motor. So this is motor. Sensory is next to motor. Now, down here in the bottom, you have your anterior horn. Anterior horn is involved with lower motor neurons, and this is motor. So right next to the anterior horn, it should make sense that this is where you find your spinal thalamic. So spinal thalamic is down here, surrounding the anterior horn. Okay? So it's easy to remember if you just think about it like this. The motor is next to sensory. It just so happens that in the posterior side, sensory is in the middle area. And towards the bottom, it flips around, right? And you'll see this common theme when it comes to neurology, which is the idea of flipping things around, going backwards. Now, I don't want to confuse you, but I'm going to repeat this theme over and over again whenever I see it. First, something starts anterior, then it ends posterior. Like you're going to see that, and I'll repeat it whenever we come up with it. So here we're looking at already, like I mentioned, cortical spinal tract. We mentioned this. We didn't describe exactly what it can do. This is voluntary movement. So this is a motor track. So really quick, guys, if you like what you're seeing, make sure you like and subscribe. Join the Instagram, join the Patreon. Any type of support is greatly appreciated. Thank you. That engages with voluntary movement. What about the anterior and the lateral? So this is the lateral, the one that I drew right now. This is the lateral. If we're looking at, let's say, the anterior, this is going to be here in this area. This is also a voluntary movement, but this is, also voluntary movement. But this is minor tracks here. It doesn't have as much as a lateral. So here you will find the anterior cortical spinal tract. Okay, that makes sense? For the spinal thalamic, you'll find it right here in front of it. So let me give you the proper colors just so I don't confuse you. Let's not confuse at all. Let's give this color. This is the anterior cortical spinal tract. Good question. Any questions, let me know. This is anterior. And then again, right in front of the anterior horn, of course, you're going to have your spinal thalamic. So let me give you a spinal thalamic, the blue color here. The anterior spinal thalamic. This is your lateral. So far, so good. So spinal thalamic, let's talk about what spinal thalamic can actually do. Spinal thalamic will cover the pain and temperature. Also, you have to know that the anterior spinal thalamic, this here is involved in crude touch and pressure. Crude touch and pressure for the anterior. Okay. So far, so good. Welcome, everybody. Welcome, everybody. Thank you for joining tonight. But let's continue. So we also mentioned this anterior horn area. This anterior horn area has the lower motor neurons. So let's be clear. We have to mention what is the difference of damage to the upper motor neuron in comparison to the lower motor neuron. This is upper motor neuron, and this here, lower motor neuron. So this is called the anterior horn. Let me also give it that name. This is the anterior horn, and this here has lower motor neuron. So if anybody can tell me, upper motor neuron, we will definitely have hypertonicity, hyperreflexia, right? These will be the problem. And you'll see this on the first date as well. So there's a little trick here that I actually should mention to you guys. Both upper motor neuron and lower motor neuron will tell you that the patient will have muscle weakness. So muscle weakness is not something good to use if you're trying to distinguish between the two, because both will have it, right? Look at the difference between upper motor neuron and lower motor neuron here. Muscle weakness is not going to be a good tool to try to distinguish between the two. Yeah, when it comes to cranial nerve, actually, so we'll talk about that as the cortical bulbar tract. We'll talk more about that, okay? So what we're looking at here, the difference between upper motor neuron and lower, muscle weakness is not something that we use. What we do like to know is the tonicity. That's the biggest giveaway. If something has an increase in tone or hyperreflexia, that is going to reflect the upper motor neuron problem. If something is atonic, the patient just lost its tone, hyporeflexia, that's lower motor neuron. Very simple. Now, the weird one, the one that can confuse a lot of students, will definitely be fasciculations, because you're thinking to yourself, well, why is the muscle like kind of twitching if the patient has a lower motor neuron problem? But just remember that one. Keep that one in your mind. Fasciculations is going to be a lower motor neuron problem, and Babinski sign is going to be an upper motor neuron problem. So anything like that, any small thing like that, it's something that I like to pick up and then ask you guys whenever we do a review or a drill. So this is something that I would take a note of. I've seen this in questions already. So I would just ask you this further down the line to make sure that you guys can remember the difference between the two. Now, I emphasize on it so much because it's high yield. So taking a look at this, we're seeing anterior horn, lower motor neuron problems. So far, so good. We went through this. Now, I'm going to show you one more track as well that we're going to add to this. Here you're going to see on the outskirts, spinal cerebellar tract. This has a lot to do with ataxia. This also has to do with proprioception. Proprioception. So you're probably thinking, hold on, didn't we say that proprioception was the dorsal column? Why do we have two different types of proprioception here? Well, let's clear it up. Something that differs between the two is that the dorsal column typically will have conscious proprioception. There's unconscious proprioception and conscious. Conscious proprioception utilizes vision as part of its characteristics in order to find out where we are located in time and space. So if I'm trying to balance myself, I could also use my vision to try to understand where my body is situated in accordance to the world around me. You see what I'm trying to say? So the dorsal column will use vision as part of its system for proprioception. The spinal cerebellar tract does not. It's unconscious. This is the type of proprioception that we utilize when we're riding a bike, right? This is the type of proprioception that we utilize when basically we're just standing still. So how do we distinguish between the two? There's going to be something called Romberg sign. So you put the patient in front of you in Romberg sign, you tell them to close their eyes. And if they start to fall over, that means that the proprioception issue that they have is pertaining to the dorsal column because they're lacking that visual characteristic and they just fall over. So let's understand that properly. It's not the same when we're talking about spinal cerebellar. Spinal cerebellar, they fall towards the side of the lesion regardless. If they're closing their eyes, if they have their eyes open, if they're winking their eyes, right? If doesn't matter because it's unconscious proprioception that is basically lost in this patient. So that's the difference between the two. So it's not the best test, the Romberg test. Why? Because guess what? If the patient closes their eyes, they're going to fall towards the side of the lesion if they have a spinal cerebellar as well, because they're falling towards the side of the lesion regardless. Okay. But yeah, that's just the difference between the two. So hopefully you guys understand that. We're going to take a time to ask questions as well to see if you guys have any questions, and we'll address it towards the end of the lecture as well. So, okay, so far so good. We mentioned the tracks, we mentioned different types of symptoms and problems. I should also add one other thing, the spinal cerebellar tract. With the spinal cerebellar tract, another thing is something called dysmetria. Whenever you have cerebellum problems, there's certain types of symptoms that stick out, and we can definitely use it to get a diagnosis with this. So the cerebellum itself, of course, it's picking up your precision of your body and it's sending it out. It's relaying that information to other parts of your brain. That's what it's doing. But there's something called dysmetria. Let's say I want to put this pen on top of this. I have an issue gauging where this is located in accordance to my own body. So I could overshoot or undershoot. That's a dysmetria problem. Right? You can tell the patient to do a finger nose test and they're missing. That's a dysmetria problem. Okay, so that's one of the biggest symptoms here that you're going to see when it comes to this problem with spinal cerebellum. Right? Perfect. So now we have a couple of tracks here. We definitely addressed a lot of tracks. And okay, that's good. So far, so good. Now let's dress up this. So yeah, for anybody who came in late, I was just basically showing the people the brainstem. We're going to now dress up this brainstem with the tracks. So let's pay attention. This is very, very crucial. We said the brainstem has the midbrain, the pons, and the medulla, or the medulla, however you want to call it. We said cranial nerve 3, 4, right down the middle, 6, and 12. Notice how they're all derivatives of 12, right? 3 times 4, 12. 6 times 2, 12. Perfect. Now for the lateral side, we said cranial nerve 5 is the superior lateral. And then we said 7, 8. We said 8 has a lot of nucleus, so we can see 8 manifesting itself here in the medulla. Then we also said 9 and 10. So far, so good. You guys understand. Now we're going to dress this up with tracks. So let's take a look at this. Something very important. Again, the reference that I made was that the thalamus is found above the midbrain. Thalamus. Not including this as a brainstem, but it's on top of it. So I'm going to give this color a yellow color, and I'm going to say that this is the cortical spinal tract, which runs down straight down the middle. Now, there's something else called the cortical bulbar tract. Cortical bulbar tract is basically the motor tract that is supplying the cranial nerve nuclei. So just how I mentioned the cortical spinal tract and how it goes into the spine, cortical bulbar tract is just involved with engaging these cranial nerve nucleus. So these tracks are easy to remember. The way I do, I pair them up. So this is like the little brother of the cortical spinal tract, runs right alongside with it, right, descending. But it's cortical bulbar. It's just engaging these cranial nerve nuclei. So that makes sense. Cortical bulbar tract. Now, I just showed you cortical spinal and cortical bulbar. Let's make sense of this. Let's make sure that we understand this properly. Because yes, this is a huge thing to get your answer right when it comes to strokes. You can just get an answer right just based on these tracks. So I'm going to show you the distribution of it. You guys understand what the homunculus is, hopefully. The homunculus. You're going to see it on the first day. They have a nice image of it. Let's simplify this and let's understand this. So looking at this, motor homunculus and sensory homunculus really is not too different. We don't have to be surgical with this. We're not going to do brain surgery. We're just trying to understand the basics of neurology. So what I do is this. I split this up. This right here looks like an A, right? You see how it looks like an upside down A? If I do this, it looks like an A. This here is going to be the pelvis and below. the pelvis, and below. Okay. Now, if I show you this, I'm going to split it again. The irrigation for this part is going to be ACA, the anterior cerebral artery. The irrigation for this lateral side here that I'm showing you is going to be MCA. Now, MCA, we're going to split this into two. Don't get lost. If you guys are confused, let me know. We're going to split it like this. You see how it says here, the brow, the neck. Look, this here is going to be the face. Face. And this up here is the trunks and the superior extremities. Okay, trunks and superior extremities. Perfect. So now, in order for you guys to memorize this very easily, so you guys don't have to get confused, I'm just going to show you one thing. Look at this guy right here. We're going to draw this guy. This guy. Let's put an M right here. So trunks and superior extremities, MCA. Then we're going to give you the inferior, the pelvic area, and the inferior extremities. This is ACA. Okay, you guys can't forget that. That makes perfect sense. MCA also, remember, covers the face. So this should make sense, right? Good, good, good. So let's take a look now. The sensory tracts are going to involve, of course, the spinal thalamic, the dorsal column, these kind of tracts. The motor we're talking about here is going to involve the cortical spinal tract and the cortical bulbar tract. Spinal thalamic, dorsal column. And remember, dorsal column, we call it the dorsal column medial lemniscus, because once it hits the medulla, it changes to the medial lemniscus. And we'll talk about that further down the line. So hopefully everybody's understanding. Everything's good. All right. So taking a look at this, we're dressing this up now with the actual tracts. We just mentioned cortical bulbar and the cortical spinal tract. If I see that the patient has an MCA type of stroke, let's say, I should not be surprised if he has issues moving his superior extremities and sensation is gone in the superior extremities and the trunk area. That should make sense. That's just an example of what we just talked about. Okay, cortical bulbar, cortical spinal. Now, I'm going to also add on the side now. Let's take a look at the side. Here we have the spinal thalamic. Spinal thalamic is ascending. I'm going to put it here. Spinal thalamic, that we said that was pain and temperature. Good, perfect. Spinal thalamic. Now, I have to mention another thing. I have to mention something else, and I hope you guys don't get confused, but this is cranial nerve 5. Cranial nerve 5 does have sensation, and it has a sensory tract with it. So cranial nerve 5 has a tail, has a very long tail, and it runs down like this. So cranial nerve 5 is going to give sensation to the face. So it runs along the side, it has a very long tail, and it gives sensation to the face. Perfect. So far, so good. We're flowing, everything's good. Now, let's add another track. And this track, it's on the first aid. It is there. You know, it is there. They do mention it, but they don't really go too much into it. So I'm going to show you something. There's something here called the descending hypothalamic fiber, and it runs down, actually down. So this is a rare thing where you have a sensory tract that's running down, but this is called the descending hypothalamic fiber. Let's learn that. Let's add this into it. This is on the first aid. Let's take a look. This here, such a small section, yet such a high yield section. This that I drew black right here is the descending hypothalamic fiber. We're taking a look at it right here. This is running on the lateral part of the brain stem, like you can see, right? This is the midbrain. This is the pons. This is the medulla. And it's running down all the way to T1. This here, if you damage this, you can get Horner's syndrome. You can get Horner's syndrome. So this is when the patient has those Pankos tumor in the lungs. It's going to push this area. And this is going to cause Horner's. So it should not be a surprise to you if we damage the lateral side of the brainstem, patient can have Horner's. Okay, because this is a system that relays. It goes down from the hypothalamus and then makes its way back up in order to innervate sweat glands and also innervate the pupillary dilators. That should make sense. And what happens when you have Horner? You get PAM, ptosis and hydrosis and meiosis. Okay, everything makes sense there. That's the descending hypothalamic fiber. They love mentioning it when it comes to Panco's tumor, but they don't really mention it when it comes to brainstem. So let's keep that one in mind as well. So far, so good. We're flowing good so far. But now we're going to mention a more confusing one, something called the dorsal column medial lemniscus. Dorsal column medial lemniscus, it was the dorsal column throughout the spinal cord. Remember, we drew this out. We said, okay, we said this area back here was the dorsal column. Now, once it makes its way up here, you have some nuclei, and the nucleus is going to be the gracilis nucleus, the cuneatus nucleus, but there's fibers that come down, and now this new fiber that makes its way up is called the medial lemniscus. This new tract here at the level of the brainstem, it's bringing the same proprioceptive information from the dorsal column, but it changes its name. Instead of dorsal column, we are now calling this medial lemniscus. And medial lemniscus has a trajectory that does this. It goes up. Let me give this a weird color that I haven't given before. Yeah, let's give it purple. So it'll go up. Let me see. Let me put it like this. Goes up, crosses like this, and then goes all the way up. So one thing I will mention, both the spinothalamic and the medial lemniscus, they're both going to join. They're both going to send the information to a nucleus in the thalamus called the VPL. The VPL, the ventral posterior lateral nucleus of the thalamus. Cranial nerve 5 sensation sends its sensitive information to something called the VML, the ventral medial lateral nucleus. Okay? And we'll add more information in the future, and I'll tell you the strong significance of this. You have pure sensory strokes, pure motor strokes. You'll see how this is important. But for now, just note that spinothalamic and dorsal column medial lemniscus tract sends its information to the VPL. Know that the VML receives the information via that cranial nerve 5 sensation. Okay? Perfect. I think that's it. We got the tracks in there. So if you guys are able to sit down and understand this properly, it'll make so much sense. And I'll show you why. I'll show you why. In the beginning of the class, we were talking about the irrigation. We said this is PCA. This is the internal structure of the PCA. We then also mentioned that the middle area is the basilar. We mentioned that the superior lateral is the superior cerebellar artery. We said this was Pica, and this is Pica. Now, there's one more thing I'm going to add. When we look at the brainstem, see this brainstem here? Looks a lot nicer this way. It looks like a mess in the other side, but this brainstem here, you're going to have the cerebellum. The cerebellum is huge, but the cerebellum does attach mainly onto the pons and the medulla. Okay? Let's say like this. And this is cerebellum. So it makes sense. You see this lateral side here? It makes sense that if you have damage to the lateral portion of the pons, the cerebellum would also be involved. So you'll have cerebellar symptoms as well. So if I damage this part here, I should expect damage to cerebellar damage. If I damage this area here in the medulla, I should expect cerebellar damage, right? Midbrain is kind of spared there. See that? So keep that in mind as well. And just to make sure we understand that, I'm just going to give this a little color here on the side. We're going to say this is the cerebellum, like it attaches to this area. Now, I didn't draw everything on both sides, but just letting you guys know that there's not just one track on one side, right? It represents bilateral, right? So we're not going to draw the tracks on the other side, but just note that the other side has the same kind of representation. Okay, now we have to put it to the test. So what I'm going to do now is I'm going to show you on the first aid, that area that talks all about these strokes. And I'm going to show you how the stroke area has all these different types of symptoms. It's like a menu. You see, when you go to eat something, they give you, oh, this comes with this, it comes with that. It has like a big laundry list of things that you need to know. Now, we don't need to memorize these lists anymore. If you're able to draw this out, and I recommend that you sit down with a blank sheet of paper and draw it out as many times as needed, just to get this into your brain correctly. So if I'm telling you guys that I have a problem with the anterior spinal artery. If I memorize this properly, if I learn this properly, look at what I have. Cranial nerve 12. Cranial nerve 12. Remember, cranial nerve 12 damage, you lick your own wounds, tongue is going to deviate towards the side of the lesion. So they're telling me that the tongue is deviating towards the right. It should make sense that right away I'm thinking this is a right ASA problem. But then I have to confirm it with the tracks. So check this out. If this is true, if what I'm saying is true, then the patient will have cranial nerve 12 palsy, where his tongue is licking his own wound, meaning this tongue is deviated towards the side of the lesion. I should have cortical spinal tract problems, so he should have upper motor neuron issues. And I should have medial lemniscus problems. Remember, medial lemniscus dorsal column had to do with proprioception. So the symptoms I should see on an ASA problem on the right side, let's say, ipsilateral, so I should see cranial nerve 12 involved. Tongue should be deviated towards the right. I should see medial lemniscus contralateral. Medial lemniscus does spin, so it does have a contralateral, decreased contralateral proprioception. And then I also should see contralateral paralysis of the upper and lower limbs. Look at that, spastic paralysis. That's upper motor neuron problem. So here, the proof is in the work. We just saw this area here. Cranial nerve 12, cortical spinal tract, and of course, dorsal column medial lemniscus. The cranial nerve lets us know if it's ipsilateral. That's why I always tell you, whenever you are now looking at a stroke question, no more autopilot. I don't want your brain to be thinking, what could it be? And because you're going to let the test writer take your brain into a journey. And then they could confuse you. Instead, you should be looking at the question thinking, what cranial nerve problem is there? Okay, what tract is involved? Those are the two major things. And then anything else would just be something that you can confirm what area is involved. So that's the way we will approach this. And I'll show you some questions as well. Let's make sure that this is fundamental and we actually know it, because from this, we're going to actually add more information, grow it, and get it bigger. So, okay, Pica. Let's take a look at Pica. It should include descending hypothalamic fiber, which is Horner. It should include spinal thalamic. Remember, spinal spins, so it's contralateral, pain and temperature. It should include some cranial nerve 8, because we did say that cranial nerve 8 has various nucleus, and it does extend itself to the medulla, so cranial nerve 8 should be involved with the vestibular, so I'm going to say cranial nerve 8. It should have problems with cranial nerve 9 and 10. No more tracks. So we're good. Let's make sure that's what they tell us. So if we look at it, Pica, nucleus ambiguous. Yeah, here, nucleus ambiguous is basically a nucleus that
is going to contain neurons that'll innervate the pharynx, larynx, and the upper esophagus, used for swallowing and for speech. If you have a problem here, you'll have dysphagia and dysarthria.
Cranial nerve 11 engages in the C1 area. So yeah, you're not going to see any kind of presentation because of this cranial nerve 11 here at this point. Cranial nerve 11 is actually part of the anterior horn area of C1 to C4, sternocleidomastoid and trapezius. So here you're seeing cranial nerve 9, 10. So you have the afferent and the efferent. So you're seeing hiccups, decreased gag reflex, hoarseness, the vestibular nuclei. Look at that. That's cranial nerve 8 that we mentioned. This has vomiting, vertigo, and nystagmus. So let's see this, nystagmus. This is another thing that we should also be very aware of. The MLF. When we talk about the MLF in the future, you're going to see that, remember when you have your vision, you have cranial nerve 6, which moves your eyes towards the lateral side. And then you have cranial nerve 3, which can shift your eye towards the medial. They have to be working in conjunction. They have to be working together. So when you're going to look at something, let's say on your left side, you're going to engage your cranial nerve 6 and your cranial nerve 3. And here you see a relay system. We'll get into that in the future, but that system is relayed, and the MLF is very important in this system. It's allowing a communication between these cranial nerves. MLF also gets its input from cranial nerve 8, and that's not what you will not see in these kind of books. You will not see any kind of information based on this. But yeah, cranial nerve 8 has input towards the MLF system. And why do I tell you this? Well, think about it. If we're looking at an object and we're moving our head everywhere, we're moving our head, we're doing this, we're shaking, or we're in a vehicle or we're moving fast, our eyeballs tend to stay in the same area. Our face can move so many different places, but our eyeballs are fixated in one area. That's because of the input of cranial nerve 8 with the MLF. All right. So when this actually has problems or any kind of damage to this, you can get nystagmus. So vestibular nuclei. Yeah, we'll get more into cranial nerves so we can understand cranial nerves is in its totality just because it's so important. But vestibular nuclei is involved. Then I told you, I said spinal thalamic. Look at that, lateral spinal thalamic tract. Pain and temperature decrease sensation, contralateral side of the body, spinal spins. Okay, now ipsilateral face. Ipsilateral face is the one that I did not include, which was the tail of cranial nerve 5. Cranial nerve 5 sensory. Remember, it has a tail. That's the one we left out. So we were able to look at this. Remember, cranial nerve 5 has a tail. So the tail of cranial nerve 5 is going to bring sensation to the face. But we got it now. So yes, cranial nerve 5, sensation to the face. Sympathetic fibers, that's the Horner one. We mentioned that. That's the descending hypothalamic. They call it sympathetic fibers, but just to be exact, that's the descending hypothalamic. Inferior cerebellar peduncle. We said the cerebellum is involved in the lateral side. Remember, I drew it as pink. So you'll have cerebellar issues, ipsilateral ataxia and dysmetria. Look at that. Everything we mentioned basically is attached to all of these strokes. We no longer have to memorize these long lists. If you just draw this a couple of times, if you understand what each track gives you, what symptom, what problem, what clinical presentation the patient is going to present, if he has damage of what track, this is the major power in neurology. This is right now the basis of everything. If you guys can sit down and draw it out, it'll make sense. Okay?